We shall now go on to our keynote speaker, Dr. Andrew Lee, and he's going to be telling us how we optic neuritis management, how have we changed since the ONTT. Can we play his video?
Hi, my name is Andy Lee, and I'm going to be talking today about optic neuritis, the good, the bad, and the ugly. The good, of course, is demyelinating optic neuritis from multiple sclerosis or idiopathic. Myelin oligodendrocytic glycoprotein is the bad, and neuromyelitis optica is, of course, the ugly. You need to know a little bit about these conditions so that you can make the differentiation between the good prognosis, optic neuritis from MS, and the ugly, which is neuromyelitis optica. In 1978, I was a high school student and I wanted to be a doctor. My second choice was Jedi Knight. And at the end, I'll tell you how I try and be the mentor that I needed when I was young. And the reality is, you have a superpower. I wanted to be a doctor, but I wanted to have this superpower and be a spaceman. It turns out that superpowers are real. The power to detect disease and death by looking in people's eyes is a real Jedi superpower. And with this great power, however, comes great responsibility. It is the Force. And so the second message of my talk is making sure that you use your power wisely. Because you're a doctor first, an ophthalmologist second, and a vitreoretinal surgeon or refractive surgeon third. And the reason it's important is you need to know about MOG and NMO because it could be good, because optic neuritis gets better. It could be bad because it could be MOG, myelin oligodendrocytic glycoprotein, which needs IV steroids and is often steroid responsive. And you might require immunosuppression, but you definitely need immunosuppression if you have NMO, which can blind you from the myelitis or paralyze you from the optic neuritis and the myelitis. And so my dad's rule of ducks, if it quacks like a duck and looks like a duck and flies like a duck, well, it's probably a duck. So here's the good. This is a typical prototype for optic neuritis, a 20-year-old white female with acute unilateral loss of vision, a relative afferent pupillary defect, pain with eye movement, and a normal fundus. The patient sees nothing. The doctor sees nothing. There's nothing to see. You give the intravenous steroids and they get better. And the MRI scan shows the demyelinating white matter lesions. And so that's a little bit bad because it could be multiple sclerosis. However, they need neurology to talk to them about immune modulator therapy. The bad news is if the MRI is normal, it could still be NMO or MLG. So it's both good news and bad news if the MRI does not show the demyelinating white matter lesions of MS. And you know from the optic neuritis treatment trial, you can see the 3 treatment arms: methylprednisolone, intravenous, placebo, oral, and oral prednisone. Intravenous steroids got better quicker, but all the groups recover. And that's the same for both visual field and visual acuity. Everybody recovers. However, prednisone in oral conventional doses is not recommended because it increased the rate of new attacks in the fellow eye. And the cumulative probability of clinically definite MS by treatment group in the first 2 years was higher in the oral or the placebo arm than intravenous steroids. At year 5, this effect did not persist. And so we need an MRI of the head and orbit with gadolinium. That was not seen in the optic neuritis treatment trial because we really didn't have these studies. This is fat suppressed. And what we're looking for is a short segment of orbital enhancement in typical MS. So if you don't give the fat suppression, you can't see this little bit of enhancement, and that's really important. So with fat suppression, we can eliminate the bright fat on T1 and see the gadolinium enhancing optic nerve. And if you look at enhancement of the optic nerve in multiple sclerosis, 96% of patients have some degree of enhancement. So if there's no enhancement, that's bad. And if there's extensive enhancement, that's also bad. But no enhancement, you really should be thinking about the different diagnoses here. And as I said, if it walks like a duck and swims like a duck, and that duck in this case is optic neuritis, well, you know what to do. However, if you have a patient who's immunosuppressed or who has fever, that's very atypical for optic neuritis. And so you should be thinking about the bad things this could be. If we see bilateral or chiasmal enhancement, you really should be thinking about non-typical optic neuritis, including NMO and MLG. And you can see the chiasmal and pre-chiasmal segment enhancement here. If we have enhancement and enlargement of the nerve, that's also a very atypical feature. And if we see the enhancement go outside of the nerve itself into the fat or into the sheath, that's also a risk factor that this is an antibody-mediated optic neuropathy. So into the sheath or into the fat is bad. And what if the brain MRI is normal? So the good part is if it's demyelinating white matter lesions, even though that's bad, that suggests it's MS, but it could be ugly, NMO, if it's normal or if the white matter lesions are not typical for multiple sclerosis. So here's the atypical presentation, a 60 rather than 20-year-old, a non-white patient, for example, Afro-Caribbean or African-American, and in your part of the world, it may be that your endemic populations are more at risk for NMO depending on where you live. Acute rather than unilateral loss of vision, no RAPD because it's bilateral, and that cancels out the R. Or if you have severe pain, these are all big red flags that it's not a duct. If the disc is swollen as opposed to normal, because typically it's a retrobulbar optic neuritis, that's also bad, or if it doesn't respond to corticosteroid therapy. So it's not a duct if it's bilateral, non-improving, progressive, or if there's disc edema. And you should know that the immunology of MOG and NMO is different than MS. In both anti-MOG related disease and anti-NMO aquaporin 4 antibody-mediated disease, the attack is on the myelin, but in NMO, the attack is compounded by astrocytic death created by complement activation in the membrane attack complex, and that leads to death of astrocytes. And so both MOG and NMO are antibody-mediated and are bad, but NMO is really ugly. NMO disproportionately affects African Americans, Afro-Caribbeans, Asians, and the Asian form of MS is more likely to look like and act like NMO. Of course, women are more common in both disorders, but especially NMO. And most NMO patients are misdiagnosed initially as MS. If you look at MS, it's found in every region of the world, but it's higher in the northern latitudes and in the same latitude in the southern hemisphere, Australia, New Zealand, not much in the equatorial regions. And amazingly, that also corresponds to wine production. So if you have good wine in the northern hemisphere or in the southern hemisphere, including Australian Shiraz and New Zealand Sauvignon Blanc, or even South African Chenin Blanc, Argentinian Malbec, these countries in the southern hemisphere and the same latitude in the northern hemisphere have MS. And so if your patient or your patients are from these equatorial regions, you really should be thinking about NMO. And this is a world map showing the prevalence of NMO worldwide. And you can see it is higher in the equatorial regions, even though it has a worldwide prevalence. In the USA, it's 11 per 100,000, but for Afro-Caribbeans, maybe 10 in 100,000. And so we're going to be looking for those atypical quacking on the MRI scan of this duct, which is enhancement in the sheath, as in this case, or the enhancement extends out into the fat. And that is the marker of myelin oligodendrocytic glycoprotein, which is a much more aggressive antibody-mediated inflammatory optic neuropathy. It's not as bad as the ugly thing, NMO, but it can be. And so neuromyelitis optica, it doesn't quack right. First of all, the MRI is usually normal or shows non-typical demyelinating lesions. The optic neuritis is bilateral, sequential, or simultaneous. And if you have the myelitis, the transverse myelitis, that's way more dangerous, especially if you have 3 vertebral segments of longitudinal enhancement. Of course, the aquaporin 4 antibody for NMO is positive, and these optic neuritis patients tend not to recover. It's bilateral, and then the brain MRI can be normal, and that is both good news and bad news. If you have a CSF pleocytosis of greater than 50 white cells, that's also suggestive that you might be dealing with NMO. And so on the MRI scan, we need that head, orbit, gadolinium, and fat suppression to look for this short segment of enhancement, which is the typical feature radiographically of MS-related optic neuritis. But when you have bilateral chiasmal involvement or longitudinally extensive disease, that is the marker that it is NMO or MOG. So here's some examples of chiasmal enhancement, as well as the longitudinally extensive greater than 3 vertebral segments of enhancement or T2 change in the spine, suggesting that this is myelitis from neuromyelitis optica. And if you look at this paper from Steroni et al. About the enhancement patterns, anything that's involving the chiasm or the tract or bilateral, those are the big red flags that this might be NMO. And on the MRI scan, what we're looking for is the white matter lesions of MS are not the typical ones, and in fact are involving the aquaporin 4 rich areas. That's the subependymal layers, the area postrema, and of course the spine. And the target is aquaporin 4 channel at the astrocyte foot process. And so when we have that vertebral longitudinally extensive enhancement, that's rare in MS, and you really should be thinking about NMO. And if you look at the path of these lesions, it's much more aggressive, active demyelination, macrophages, necrotic debris, and the attack involves the membrane attack complex, and that makes it a lot more dangerous. And so when do I order the NMO antibody? Non-recovering optic neuritis, less than 2200 vision at onset. Bilateral, simultaneous, or sequential is a big red flag if it's recurrent and if the brain MRI scan is not typical for MS. The atypical quacking of the duct, the MRI scan is normal, or the lumbar puncture shows CSF pleocytosis greater than 50 white cells. And of course, if you have transverse myelitis, all of these scenarios, we're going to be ordering both NMO and MOG. And so if you look at this Mayo Clinic slide, I definitely order it on vertebral 3 longitudinal segment disease, multiple recurrent episodes or non-recovering optic neuritis or bilateral simultaneous, especially if the chiasm is enhancing. I do order it on single episode optic neuritis and short spinal cord lesions if the MRI of the brain is not typical for MS because it changes the outcome. And so if you look at the cumulative survival in the Kaplan-Meier after transverse myelitis or optic neuritis, at time 0, this person is only seeing ophthalmology. If you're NMO negative, fine, that's a duck, quacks like a duck, flies like a duck, treat it with intravenous steroids, it gets better. And you have to worry about MS in that patient. However, if the MRI is normal or any of the other features that I told you that are atypical, if you don't do anything, a transverse myelitis event is going to occur in 40% of the people within the first year, and a recurrent optic neuritis event is going to occur within 2 years in 80% of the people. And so the cumulative survival defined in terms of an NMO-related transverse myelitis or recurrent optic neuritis event is quite high untreated. And so if you look again at NMO seronegative patients against seropositive patients for the development of transverse myelitis, this is paralysis, you can see a very large proportion of the people, if you wait long enough, are going to get a transverse myelitis event, and that's paralysis and even death. And so we need to make sure we make the diagnosis at time 0. So in summary, you should be testing for MOG and the NMO antibodies, which is the aquaporin 4 antibody and NMO, in the post-optic neuritis treatment trial era, because it could be good. The optic neuritis will get better if the MRI scan is normal. That's idiopathic optic neuritis. You're looking for a short segment of enhancement. However, it could be bad if it's in the sheath or into the fat. You'd be thinking about MOG and NMO. If it's longitudinally extensive in the spine or longitudinally extensive in the brain, you should be thinking about NMO. And longitudinally enhancing lesions more than half the segment of the optic nerve is generally what we consider that. And that could be ugly because NMO can blind you. And without treatment, if you're aquaporin 4 positive NMO, you're going to get a transverse myelitis or a recurrent optic neuritis. And we need immunosuppressive agent, not immunomodulatory agent for those patients. I told you in 1978 that I wanted to be a doctor. And my second choice was Jedi Knight. It turns out I get to do both. And so in the post-optic neuritis treatment trial era, you need to know that it could be good. Optic neuritis from MS or idiopathic, we give that intravenous steroids, even though the optic neuritis treatment trial says you could give nothing, placebo. Please don't give oral steroids in that setting because that increased the rate of recurrence. It could be bad.
That was an amazing talk. So much of information we got in less than 15 minutes. And I think you missed out the last slide. I would just ask one basic question before I hand it over to Murli. Now, do the MRI signal abnormalities which are seen in these modern high field scanners, would they give more information or the same risk of systemic disease as the earlier MRI machines were giving?
Yeah, so in the optic neuritis treatment trial, that was in the 1990s, we didn't have contrast, we didn't have flare, we didn't really have fat suppression, and we weren't really looking for the thing we're looking for now, which is that longitudinally enhancement or enhancement in the sheath and the fat. That's for MOG and NMO. And so in the past, we really didn't care about the enhancement pattern, but now we do. And in your part of the world, you really have to care about it because you're much less likely to have MS in your part of the world and much more likely to have MOG and NMO. And so that's why the MR that you heard in the first talk, head, orbit, gadolinium fat suppression, is a super important thing. And the pattern of the enhancement is super important now for helping you as the ophthalmologist or neurologist make the diagnosis of NMO and MOG before the antibody test arrives.
Oh, yes. Murli?
Dr. Andruli, I have a couple of questions. We got to manage a few patients who developed optic neuritis after having this COVID vaccine. We are using the Covishield, which is a licensed production from AstraZeneca adenovirus platform vaccine. So two of them had just a small segment enhancement of the optic nerve, and the third had recurrence of multiple sclerosis. So in all three cases, the neurologist said don't have the second dose. So would that be your approach too, or how to take a pragmatic approach to this problem, because it may just be coincidental, may not be vaccine related also. So in all these
the whole point of the vaccine is to stimulate your immune system. So it's completely biologically plausible that it could induce both the regular optic neuritis and the antibody forms, NMO and MOG. And there have been many cases of NMO and MOG antibody induced after COVID, the disease, and COVID-19 vaccine. So it's completely plausible. But because there's so many million people getting the vaccine, some of those, of course, are coincidental. There's no way you can answer this question scientifically. So you just have to accept that that's a possibility.
So it's okay to recommend not to take the second dose of vaccine? Is that?
I personally tell them that they're going to have a re-challenge if they have the vaccine, so they might get it again, and they have to make a risk benefit. For me, I'd rather have optic neuritis than COVID-19.
Okay.
I have one more question, Dr. Andrew. One is that when it was reported that the sera of the patients who were enrolled in ONTT were preserved, and when they were tested, only 4 of them tested positive for MOG and none for NMO. Is it that these are the incidence of these diseases has gone up, or is it because of the rigid inclusion criteria that the ONTT had that NMO and MOG didn't really fit into the study population? So what is the reason why?
Yeah, so in the optic neuritis treatment trial, they were specifically looking for idiopathic and demyelinating MS-related optic neuritis. So the inclusion criteria already are going to make it less likely. And I actually don't order the NMO and MOG if it's clearly multiple sclerosis. So if the MRI shows the typical demyelinating white matter lesions of MS, I don't order NMO and MOG on that person. I do order it if the MRI is normal, or if it's atypical in any way, or if it shows that longitudinally extensive enhancement or into the fat or in the sheath. In your part of the world, I think you probably do have to order it. And I think that's publication bias. The optic neuritis treatment trial is a Western white female study and not really an Indian subcontinent study. So you really shouldn't apply the stuff you learned in the ONTT to your part of the world. And that's even more true in the NMO-MOG era.
Why is it that the oral steroids actually increase the risk of recurrences in optic neuritis treatment trial? Is there a reason?
So we know that oral steroids in higher doses, like 500 milligrams of methylprednisolone, do not produce the effect of recurrent optic neuritis. So it's not the route. It's not oral versus IV. It is the dose. And basically, 60 milligrams of prednisone is not the same as a gram of methylprednisolone. So it's not the route, it's the dose. You can give oral, just you have to give it in higher dose, 500 milligrams of oral methylprednisolone. I think you should give intravenous, though, for optic neuritis, because you can't tell in the beginning who has the NMO and MOG. So that's another change from the optic neuritis treatment trial, where you could give nothing. I don't think you should give nothing to optic neuritis anymore, and especially if it's the MRI is normal, or if it shows something that looks like NMO or MOG. That's going to do badly if you don't give the IV steroids. But the bottom line is, if you're going to shoot a bear, shoot to kill. That means intravenous methylprednisolone. If you shoot with a 60 milligram, you're just going to make the bear mad. It's better not to shoot at all. Don't shoot the bear or shoot to kill. Don't shoot with a 60 of prednisone.
Do any of our expert panel have anything to ask Dr. Lee before we go on to our next speaker? I think there is a fountain of knowledge here to gain from. I think his talk has given a total clarity to everything. So do stay on with us, Dr. Lee. We would, as we go on to other speakers, and we would want your contributions along the way. Thank you very much. Thank you very much for an amazing talk.